continue our discussion about for the math plus protocol for the management of the COVID-19 patients. So let us start our discussion. We are going to look at, yesterday we looked at the part of the protocol that was for prophylaxis and the patient management at home. Today we would start looking at the patient management inside the hospitals, and we would see how far we can go. Maybe we can cover the whole remaining protocol, but what I would like to cover today is the labs. Why are those labs important? What kind of cells and mechanisms are working to generate those labs? And then finally, what are the medicines that are used to take care of the patient condition? So let us start with that. So second part of the math plus protocol, fascinating and a great document that has been put together. Again, the authors say that we are not claiming that this is the magic bullet, but after all of their studies, this is what they feel is the right approach. And this approach has a couple of points that go against the traditional management that we are doing at this time in hospitals. And that is, number one, the authors in Math Plus, they recommend delaying the invasive ventilation. And secondly, they recommend administering steroids, which have been contraindicated or stopped by even WHO. So these are the two core things that are different. And the document that they have put together and the discussions that we are doing, in those discussions, we are understanding what is their set of concepts and rationale to say that ventilators should be delayed and number two, steroids should be used. So let us continue our discussion. Hello, everyone. And today we would continue with our second part of the Math Plus. I'm going to share my screen and we'll go from there. Let me just set it up. Okay, ready? All right. So in the discussion today for the Math Plus, what we are going to do is the following. We are going to start from here. The basic idea of the second part of this document is the in-hospital management. And the important thing here, which I would like us to look at, is the following. If you see here, this is part of the document. And what page is this? Page number 9 of 17. So if you see here, what they're saying is that the disease progress, COVID-19, is when the virus appears in our body, when it arrives in our body, we are first asymptomatic, and that is correct. The virus arrives in our body for a few days, anywhere from 2 days to 5 days to 14 days. We have talked about it many times. We will be asymptomatic while the virus is replicating and the viral load is increasing to the point where the symptoms start appearing. So we go from infection to disease. So the virus comes into our body. The first stage is that we are asymptomatic. At that time, interferon type 1 are increased, and so they are detectable in the labs. With that, there is a mild increase in interleukin 6, and we have discussed that, and we'll look at that again today as well. Interleukin 6 is released by many kinds of cells. Remember when we talked about tocilizumab, we talked about all those cells that can produce interleukin 6, and then all those cells that respond to interleukin 6 and enhance the immune system. So here the authors are looking at these 4 labs: interferon 1, interleukin 6, D dimers, and ferritin. So I'm happy that most of us, with our discussions, we know what interleukin 6 role is. We also know what D dimer's role is. Remember when we talked about the hypercoagulability, that is when we talked about it, that D dimers are an indication that thrombi are forming or coagulation is occurring, the vascular damage is happening, and possibly embolism is also occurring, which may give rise to tissue damage, lung damage, organ damage, COVID toes, maybe possibly because of that. Then strokes that were observed are possibly because of that. And then ferritin, we have not talked about it, that why will the ferritin increase? So we'll talk about that today, and interferons. But let's look at how they look at the labs and consider this in this labs, in this diagram. What they're saying is that in the beginning, it is a virus damage that is occurring. Then the damage transitions, moves from the damage by virus to the damage by the immune system. So in the later phases of the disease, in the severe phases of the disease, it is not the virus itself that is the main role player, but it is the enhanced and amplified and immune system that has gone nuts that is causing the damage. So if you see here, after asymptomatic, mildly symptomatic, again, this is still a person at home, some more interferon up, some more interleukin-6 up, and ferritin has started appearing as well. For the time being, till I explain the mechanism of ferritin, just keep in mind that ferritin here is going to indicate two things to the clinician. One, that ferritin is released by macrophages, and secondly, with the iron metabolism, and we have an iron metabolism related important discussion to do today as well. And the second thing is ferritin is also an acute phase protein. So remember those proteins that are released from the liver as when the infections or stress to our body occurs. Ferritin is a similar protein as well, that is an acute phase protein, although this protein is present in many other cells other than the liver or in addition to the liver. So mild symptoms, these three labs have gone up. Then thrombophilic stage. So remember, this is the stage of the pathology of the drug, of the COVID-19, not the symptoms. So thrombophilic stage is when the thromboembolism has started, when the hypercoagulable state has started, when the overactive immune system is now causing damage throughout the body, plus the virus itself is causing endothelial damage. So thrombophilic state, and if you see here, now this red arrow of D dimers has gone up because this is indicating that hypercoagulable state has started. And we have done this discussion twice in quite a large extent. So I would keep this short here, but I want to see the labs together. Then early pulmonary phase, where the pulmonary, the lungs start getting damaged. And so if you see here, interferon 1 is going down now. So that viral response system is sort of, virus itself and the damage itself may be calming down, but the immune system damage is going to start increasing and the lung damage is increasing, maybe because patient is either getting the cytokine storm or later on going on to a ventilator. So here if you see, in the early pulmonary response, interleukin-6 has increased, which is the indicator for the cytokine storm. D dimers have sort of not that much increased, staying calm or came down a little bit. So hypercoagulable state is still there. And then ferritin is increasing, which is an indication of the iron metabolism plus acute phase of inflammation. Then if you see here, late pulmonary inflammopathic, here interferon 1 is even more reduced, but other things, interleukin-6, D dimer, and ferritin, which are all indicators of severe inflammation, are now all in the red. And finally, in the late pulmonary macrophage activation syndrome, or a syndrome where a cytokine storm-like thing is happening, then if you see again all these three labs, D dimers, interleukin-6, and ferritin have increased. So this is their basic criteria to look at how the patient is progressing clinically. With this, they also have shown a couple of things that I want to show here. Look at this diagram. In this diagram, they are saying that we have administered glucocorticoids or steroids at this part. And here, if you look at this, I think this is the C-reactive protein. So if you look at here, C-reactive protein is another indicator of acute inflammation going on or acute damage or acute infection. So here C-reactive protein, which is also released by liver when interleukin-6 works on it, when interleukin-1 works on it, but primarily interleukin-6, C-reactive protein is increasing. And as they administer steroids, then the C-reactive protein starts going down, which is an indicator that the damage to the body and the inflammation and the infection is going down. So this is a very important thing. Remember that the corticosteroids have been contraindicated by WHO and CDC. So the authors here are saying that is an incorrect thing, and here is a proof. Then I want to show you one more lab here. So this is another lab where when they dropped the steroids, then here we are, and then they started the steroids again, and the chart goes back again. I believe this is the premature discontinuation of corticosteroids and IV vitamin C. So one more thing that they said, and that is really, really important, and I have observed that as well, that if we stop the medication prematurely, if we think that the patient is doing good and let's just stop the medicines, sometimes there is a severe rebound of the infection. So that is the rebound. They're saying that so infection was going down, then they stopped the steroid here, and then the infection or the inflammation, I should say, has bounced back up, where then they started the steroid again and they started capturing the problem and reducing the problem. So again, till the discussion so far, the point of view that I want us all to keep in mind is that they are saying we should use steroids, and they are trying to prove that, hey, look at the data here, using steroid is very important. And why is it that they are harping on the steroids? Because in the conventional wisdom today, we do not use steroids to help manage the COVID-19 patients. So with this, let us now look at the management, and I would start explaining some of the mechanics of the management. So remember, yesterday we did these two. We talked about prophylaxis, and we talked about the symptomatic patients at home. Today we are going to talk about mildly symptomatic patients that are in the hospital, and we'll talk about that. So there is a comment from Siddhartha, what is y-axis IL-6? Maybe that was on the graph. So we'll look at that. So Ziaul Haq says, at what stage we should administer steroids? So look at this. So because they have their whole management protocol here, we can actually see where they are going to start adding the steroids. And if you'd see, they would do that here. So check this out. Symptomatic patient at home, mildly symptomatic patient in the hospital. Look at the drugs they're giving. Vitamin C, 500 milligram BD every 6 hours. Quercetin, 250 to 500 twice. Zinc, melatonin, and we'll talk about the melatonin mechanism next week. We'll talk about aspirin mechanism next week. We'll talk about the famotidine next week, plus steroids. So we'll do those drugs that are here, for example, enoxaparin as well. We'll do the mechanism of actions of those drugs next week. But today, let's just go along with what they're talking about. So melatonin, then vitamin D3, 2,000 to 4,000 units. Enoxaparin, which is an anticoagulant. So they are now starting to manage hypercoagulability, and they've started the enoxaparin here. Then methylprednisolone or methylprednisolone. So the question here, Ziaul Haq had asked that when are they starting the steroids? So as you can see here, as soon as the patient is mildly symptomatic and they are in the hospital, that means they may need oxygenation as well. That is when the steroids have started. So 40 milligram every 12 hour increased to 80 milligram every 12 hour in patients with progressive symptoms and increasing CRP. So look at the criteria here, C-reactive protein or acute phase protein. As that is increasing, that means inflammation is increasing. That means we need to increase the steroids. And the role of steroid here is to suppress the inflammation. So this steroid usage is a unique thing in this protocol. Then famotidine, we talked about it yesterday. it is actually an anti-ulcer drug, but somehow it has a protective effect in COVID-19. Then they have put remdesivir as optional. Of course, I think that now with the latest studies and with the approval from CDC, remdesivir can come out of optional and become part of the protocol. Then continuing on, ivermectin. Once again, they have put that as optional. I will make it as part of the protocol, and they have started it in the mildly symptomatic patient that even would need oxygenation. So if you see here, this is oxygenation requirement. I would start giving ivermectin here in symptomatic patients at home. They should not be moved to a point where they have to go to a hospital. I hope that everybody stays at home and everybody becomes cured at home without going through the misery of becoming so ill to go to the hospital. But here, if you see here, ivermectin is started as an optional. I will make it permanent, and then nasal cannula, 2 liters per minute if required. So if required, oxygenation has started. Avoid nebulization and respiratory treatment. Avoid CPAP and BiPAP, and transfer early to the ICU for increasing respiratory signs and symptoms and arterial desaturation. So Ziaul Haq, there is a good question that is it okay to start oral steroids at home with mild symptoms? I would feel that steroids should only be administered when a patient can be closely observed, because it can cause suppression of the immune system leading to viral load increase. And what I do not know, and they have not indicated that in their study as well, that if the steroids are used early at home, would that actually be detrimental or not? And I have not used steroids in my patients at home, so I cannot say from my own experience as well that would that be okay or not. So this is the stage of the mildly symptomatic patient. I want to discuss some of the mechanisms that are involved in this stage. So let us go there. We will probably have one more talk tomorrow where we will talk about the respiratory symptoms. For example, when the shortness of breath has started, what will we do at that stage? Maybe we can do that today as well. So let's look at some of the mechanisms involved here. Do you know that I feel very proud that yesterday when we were going over the prophylaxis and the at-home treatment, even after the discussion we did, I kept thinking that we all had been discussing this and we all knew it. And that power of knowledge and education and knowing that how to manage, it is verified here. And I'm very, very happy for all of us that we are at that stage of understanding of this disease and its management. Okay, so let's look at this, mildly symptomatic patients. So first of all, in hospital management, the first and most important thing is the macrophage. Remember, we have done this discussion in the past, and I'm going to show you that here very quickly as well. So here, this is a macrophage. We have done this discussion many times that macrophage or a dendritic cell. So here is the dendritic cell. A macrophage or a dendritic cell, when they pick up a virus, for example, in our case, the coronavirus, when they pick it up, they would then process that and present that on their MHC2 component. So this part here is called the MHC2. Then a naive helper T cell, a T cell that does not know what is its purpose in life. It is called a T helper 0 cell. Unfortunately, the poor thing, we even call it a 0 cell. That cell connects with the macrophages, and when it connects, we have talked about it, that there are co-stimulations and there are kisses and hugs that happen. And the result of that is that in the presence of various interleukins, the T helper cell 0 transitions to either T helper 1 or T helper 2 or T helper 17 or T helper regulatory cell. And we know this, that T helper 0 goes this way towards a T helper 2 in the presence of interleukin 4. And when the T helper 2 cell becomes active, it releases interleukin 4 and 5. And that interleukin 4 and 5 causes the B cell to become active, which then release antibodies. And that is what we need for coronavirus. So this is the pathway. This is the pathway that is used by our immune system, or that is taken by our immune system when coronavirus hits us. Then we also know that in some cases, and even in the coronavirus cases, in cytokine storm, there can be the presence of interleukin 12. And interleukin 12 presence can cause the T naive cell, this cell, to become T helper 1 cell, which in turn releases interleukin 12, which causes a cytotoxic T cell to become active, which will then kill the other cells. And I see there is a comment, Dr. Bill Gates says class switching. So absolutely, over here, IL-4 and IL-5. IL-4 causes class switching of the B cells to make various kind of antibodies, for example, IgE, IgG, and the IL-5 causes the differentiation of the cells to make them more, to increase the army. So now going back here, we are talking there in the previous slide, we were talking about this macrophage. So let's go back to the macrophage. If I can now find it, here it is. So macrophage, when it becomes active, we just saw what it does. But I want to show you a couple of more things that are important for the math plus, and I'll keep calling it plus plus because there is an additional plus that is from us, the cool beans. The math plus plus protocol, couple of things are important. One is the interleukin 1. So interleukin 1s are released by many cells, including macrophages or the immune system cells. And remember that in their protocol, they are measuring interferon 1, interleukin 6, and the interleukin 1 as well. So I should have actually said interferon 1 here too, or type 1 interferons. So these are released, number one. Number two, the macrophages, this is now a new thing that we're going to talk about. Macrophages store iron in them. Iron in our body is found in two areas. Number one, it is transported in our serum and it is present inside the cells. The cells that contain iron in them as a store are macrophages and bone marrow cells. Macrophages, how do they happen to find iron? They normally sit in spleen. There are lots of macrophages that are in spleen. Our red blood cells, the one that have become a little old or have become worn out, those red blood cells are eaten up by the macrophages. Macrophages eat them up, break them down, take the iron out of them, and store the iron here inside them, inside of the macrophages. And this little basket, so imagine that these rounded things are the iron. These are stored, connected to proteins. These proteins are called ferritin. And this is why I had been talking about, I wanted to talk about ferritin, because here in the Math Plus protocol, they are looking at the ferritin levels. And it's a very common thing to look at ferritin levels in ICUs. So ferritin is a protein. Here, this basket, this protein is the ferritin that binds the iron, and that is how iron is sitting stored inside a macrophage. Now, some of this iron can actually be moved out of the macrophage, and that is done through ferroportin. So there are channels in the macrophages or cells that have the iron stores. They have a channel in them. That channel is called ferroportin. Ferroportin channel puts the iron on another protein which is called transferrin. So transferrin protein, here this little trolley is that transferrin. Transferrin protein will pick up the iron and move that in our blood. So when iron is being transported in the blood, it is sitting on a ship. That ship is called ferritin, transferrin. When the iron is sitting inside a cell, it is bound to a protein, and that protein is called ferritin. Now the question is that why do we bind it to a protein? That is because the iron is prone to rusting. Remember, it gets oxidized. So because iron can react with the reactive oxygen species, then that iron can cause damage to us. We protect that by packing it up into a box, and that box is the ferritin. So hope this is now clear that when a macrophage is active in the spleen, for example, it has iron in it, it has iron stores. Similarly, the cells in the bone marrow have iron stores. And the iron that is moving around in the blood is connected with or put on transferrin, and that is what is moving around. Now, what is the role of ferritin here? When there is more ferritin produced, there can be two reasons for the ferritin to be increased. One reason is when there is an active infection and stress on the body, then we produce ferritin in larger quantities and the serum ferritin level would increase. So that is the acute phase ferritin protein. So that is one way that ferritin increases. So if you as a doctor look at a patient and the patient's labs and the ferritin level is increased, that means that there is some sort of infection going on. The other possibility of ferritin being high is that this ferritin, this little basket in the macrophage, this can leak out as well. Some of it, a small quantity, leaks out in the serum. So the ferritin in the serum is an indicator of the ferritin levels inside the macrophages or the iron storing cells, plus any acute phase reaction. Now, if the ferritin is increased, that means there can be two things going on. Either there is an iron metabolism issue, or there is an overactive macrophage, or there is an infection going on. So in case of COVID-19, you would see majority of these three things will be happening, which means ferritin levels would increase. That is why they are looking at the ferritin here. So if you see here on the right side of the page, there is ferritin, and if you see the amount of ferritin continues to increase. What does that mean? First, there was macrophage activation, then there was overwhelming infection and inflammation, then there was acute phase reaction, and that caused the ferritin levels to increase. So hopefully this part is clear. Increases when macrophages become active, and this is another thing that the authors of this study, or the people who have written this and working on it, they have said that ferritin also increases when we have a macrophage activation syndrome. Now, macrophage activation syndrome is what? Let's quickly look at that. I'm going to go back to this diagram. So nowadays we are tossing between them, and I'm going to use this area in a second and explain that once more. So look, here is a macrophage. Macrophage has coronavirus in it. It ate it up, and the coronavirus is presented in the macrophage. Macrophage connected with the T helper 0 cell or naive cell, and we know the hugs and kisses occurred, and that caused either T helper 2 pathway or T helper 1 pathway. Imagine we have interleukin 12 and we went incorrectly to T helper 1 pathway, which then causes interleukin 2 release and causes the cytotoxic T cell to become active, which we didn't want. The cytotoxic T cell is going to kill so many cells now and cause destruction. And remember that this arm is also going to cause T helper regulatory cell to become active. This is also going to release interleukin 21 and others that are all pro-inflammatory. We had this discussion in tocilizumab discussion. But important thing here is to note that T helper cell 1, when that becomes active, it releases interferon gamma or type 2 interferon. Interferon gamma goes back to macrophage, connects with the macrophage and makes it active. So your question should be, wasn't the macrophage already active? It was working already. What do we mean by macrophage becoming active? So here's a difference. A normal macrophage that is yet not active will pick up the pathogens, for example, coronavirus or other tissue damage or other bacteria and fungi and everything, and present that to the adaptive arm. That is its normal, regular function, baseline function. When we pour interferon gamma on it, then the same macrophages, they become hyperactive. That is what we call activation of them. What they do is they start eating pathogens with a very rapid speed. So activated macrophages can start eating up to 100 pathogens or other broken cells, and then they die as well. But now they do it in a very fast speed, number one. Number two, these activated macrophages would start releasing more interleukin-1, they would release more interleukin-6, they would release more tumor necrosis factors, they would release more NF-κ-beta, and many other chemical substances. That is going to increase the immune system response a lot. This is happening because we went incorrectly in this direction. We wanted to go in this direction. In this direction, T helper 2 direction, remember we had interleukin 10, which will then come in and tell the macrophages to calm down, stop being mad, and stop the inflammation or reduce the inflammation. Here, we went into the wrong direction, which caused interferon gamma to become available, which caused the macrophage to become active or go mad. And when it has gone mad, it has become hyperactive, and it is going to release so much interferons and so many cytokines and chemokines and cause inflammation. Okay, so now let's go back here. Where were we? Here. So this is called macrophage activation syndrome, where a macrophage or set of macrophages have become too big. And I have a study here to very quickly just show it. This one, not this one, not this one. IL-6. Okay, so, here, the very first page. This is, and I have put the link out, macrophage activation syndrome. Here is an important thing to note from here. Macrophage activation syndrome is different from cytokine storm. It looks like cytokine storm, but it is caused by a different set of cells and different set of chemical substances. It looks the same as a cytokine storm. So this is why it is important to note that it is a macrophage activation syndrome, so that we can then calm that down, and to calm it down, we need steroids. So now let's look at the drugs that they are saying to use. We know some mechanism now. Sorry. We know some mechanism now. We know that macrophages have gone mad. We know that immune system is now getting mad. It's not just the virus causing the damage. It is the immune system causing the damage. So what are the drugs they are giving to a patient who is probably requiring oxygen and becoming aggravated and deteriorated? We have seen a lot of drugs already here. So I'm not going to talk about those that we already have talked about. For example, vitamin C, quercetin, zinc, we will not talk about them. Vitamin D, we will not talk about them. Melatonin next week. So here, enoxaparin and methylprednisolone, I'm going to talk about these two, and very quickly. So they're saying that give enoxaparin. Enoxaparin it potentiates antithrombin. Remember when we talked about hypercoagulability, over there we looked at how the clots are formed and how clots are broken. So here we have antithrombin. Enoxaparin connects with antithrombin. Here this blue box here is the antithrombin. Enoxaparin is this guy that is leaning on the antithrombin and making it strong. both of them together, they trap the factor X or factor 10A. They bind with the factor 10A and irreversibly block it. Factor 10A is very important to cause clotting. So what is happening is that enoxaparin is working with antithrombin, which is part of our body, and then they are blocking the function of active factor 10 to form the clots. So this is how enoxaparin would prevent clotting. Secondly, we are talking about steroids or glucocorticoids or methylprednisolone here. Generally, what would happen is that the glucocorticoids or steroids reduce pro-inflammatory gene expression in our cells. So our immune cells, remember all of those cells that we just saw, they have genes that open up, which would then cause them to release interleukin 4 or interleukin 2 or interleukin 12 or interferon gamma or IL-1 or IL-6 or IL-8 or tumor necrosis factor and so on. These glucocorticoids can calm them all down. So they reduce pro-inflammatory gene expressions and they promote anti-inflammatory gene expressions. So how do they do that? In a very high level, steroids is a very big topic to discuss. So I'm going to do a bigger, higher level discussion. So here, glucocorticoids. Look at this diagram here. What we are seeing here is this guy, this red guy is the steroid. It has entered a cell's nucleus. It is hugging the nucleus and helping the nucleus work with the gene expressions that is going to produce lipocortin 1. So the genes are going to produce lipocortin 1 when the steroids enter a cell and tickle its genes. Now, when the lipocortin 1 is produced, what that does is in a cell's membrane. So for example, let's say this is a cell. This whole thing is a cell, and this green thing is a cell membrane. This thing is a cell membrane. So in a cell's membrane, we have phospholipids. I hope that we all know this, that the cell membrane is made up of a lipid bilayer. We call it phospholipids. In the membrane of the cell, there is an enzyme phospholipase A2. That enzyme works on the cell's membrane components and convert them into arachidonic acid. Arachidonic acid then is worked on by two separate type of enzymes, either cyclooxygenase or lipooxygenase. Cyclooxygenase causes the arachidonic acid to become prostaglandin. Prostaglandin in turn make thromboxane 2 and prostacyclins or prostaglandins. And the lipooxygenase helps make leukotrienes. And what are these things? Majority of these things are pro-inflammatory. And look at how glucocorticoids work on them. The lipocortin blocks phospholipase here. It blocks it. When that is blocked, arachidonic acid is not made. When that is not made, then prostaglandins are not made, leukotrienes are not made, nothing inflammatory happens. So all inflammatory chemicals that are being formed are gone. So that is one function. Lipocortin also directly works on cyclooxygenase enzymes as well and block them too. And so it stresses the prostaglandin suppression in two ways. One, directly working on phospholipase A2, and secondly, working on cyclooxygenase. Good. So the takeaway here is that steroids would enter a cell and they would cause the cell to release liponectin, lipocortin. Lipocortin would then work within that cell and cause the inflammatory products to not be formed. Secondly, and this is very, very important, look at this. Steroids are able to almost shut down the whole immune system by reducing the immune system cells adhesion, and we'll talk about that in a second, emigration, chemotaxis, phagocytosis, respiratory bursts. What does that mean? So here, Let's talk about that for a second. Let's say this is a tissue cell. This cell had a virus in it. That cell got broken down because of the virus. So here is the cell is now broken down. When the cell is broken down, that causes the local macrophages and neutrophils and other things to become active. Plus, because there was a virus there, we know that the macrophage itself has become active. Now what would happen is these chemical substances that are being released from broken cells, broken tissue, and from the active immune cells, they are going to cause, so let's say this is a blood vessel. So remember we had a bird analogy with the chemokines. Chemokines are the chemical substances that are released from the broken tissue and the immune system, which are actively fighting some pathogen. These chemokines cause the cells that are circulating in our blood, for example, let's say T cell, or let's say other macrophages or neutrophils, the cells that are circulating in our cells, happily, they're just floating around. These cells, when they pass through an area where a damage is occurring, these chemical substances make the cells stop floating around and extend a hand and grab onto the cells of the endothelium. This is called adhesion. We want the cells to adhere to the cells of the blood vessel that would stop these immune cells in that place. Then what these cells are going to do, these floating cells, they are going to squeeze through the blood vessel wall. And this is called emigration. They are now emigrating from the blood vessel and entering the tissue. They are here to fight. So first they extended a hand, hold on to the blood vessel cell. Then they now are squeezing through the blood vessel cell. They can even make small holes in the cells, and they would now come out. This is now the process of chemotaxis. Then these cells would now keep moving to the area of the fight. Over there, they would start becoming active. They will fight, and they would release even more chemical substances, which would call even more immune cells over here, and the fight would just keep ramping up. Steroids can work on these immune cells. And what do they do? So let's say if a steroid has connected to an immune cell and gone into the immune cell and caused the gene expression here, gene expression in this cell, what is it going to do? It is going to tell this immune cell to not exhibit or express the molecules that would help it with adherence. So it will not let it extend its arm and hold onto a cell of the vessel wall. So cell will not slow down, immune cells. Secondly, even if the cell slows down, the steroid hormone is once again make the immune cell disabled from being able to emigrate. So they would stop the process of emigration. Even if the cell has emigrated, steroids are going to stop a cell from becoming active, from releasing more chemokines, from releasing more cytokines, and taking part in the fight. All of those mechanisms are going to dampen the immune system so much that we call it immunosuppression. Everything is dampened. Everything is calmed down. So now if I see here, look how steroids, so these dudes, these red guys are all steroids. When the steroids work with monocytes, or they work with macrophages, or they work with dendritic cells, these are all the cells of the reticuloendothelial system. These are the cells that are either living in, monocytes are present in our blood vessels. Then the monocyte come out of the blood vessel, then they go into the tissue, they take a residence there, and they say, you know what, I love to live here. This place under the skin is awesome. Or I would love to live in this GIT place or this liver. I am going to make my home here forever. So when a monocyte settles down in a tissue, it is called a macrophage or it is called a dendritic cell. So these cells together are called reticuloendothelial cells. These cells, the macrophage and the dendritic cell, that are now living inside the tissue are called histiocytes. Why do we call them histiocytes? Histio means tissue, cyte means cell, cells that are living in the tissue. So a steroid or steroid drugs can actually suppress all of these three. Remember, monocyte is like the parent, and the macrophages and dendritic cells are not parent and child, but monocyte, when it takes residence, is called a macrophage or dendritic cell. And steroid, when it acts on them, it reduces their cytokine production. So all of our body's macrophages and dendritic cells that are sitting all over our tissues, steroids go there and stop and reduce their function. They cannot release more cytokines. They cannot call more people over there to make a fight. Then they release their chemokines. The difference between a cytokine and a chemokine is cytokine is any chemical substance that is released by any cell that goes and signals to another cell. That is a cytokine. A chemokine is a specialized signal that asks the immune system cells to come over there, wherever this cell is, and start taking part in the fight. So cytokine are reduced, chemokine are reduced, and look at this. Reactive oxygen species production is reduced. This is called respiratory burst. So most of these cells, let's say we have a neutrophil here. I make them like this, that most of these cells have a grill in them. You know, the grill that we have, that we, in summers, we fire up our grills and we cook meat. These cells, the macrophages, dendritic cells, and the neutrophils, they have a grill in them, lysosome in them, where they put the coronaviruses, for example, and they do a respiratory burst on them. They create a lot of reactive oxygen species in here. That reactive oxygen species, these monsters, help break the pathogen. This is called respiratory burst. How I remember that is that, imagine if this is a magician, this is a wizard, and that wizard then casts a spell by saying woo, and then that thing dies. So these reactive oxygen species are produced when the cell creates a respiratory burst, and that burst is like a fire that occurs, and that fire burns the pathogen and breaks it up. The steroids reduce the production of reactive oxygen species in these poor cells that were trying to help us. So of course, in a patient where the immune cells have gone nuts and they are causing damage to us, giving steroid is actually a useful thing because we want to calm them down. The only thing is, which is still a curiosity for me, are we going to, and this was a question here as well, that are we going to calm them down when in the early stage, like at home, or in the hospital in the observation of a doctor? My preference will be in the observation of a doctor, or if you are a doctor and you can keep a close eye even at a patient at home, then sure, steroids can be used. Now, the other thing that steroids do, so as you can see, these three dudes are here. Other thing that steroid does, if you look here at T helper 2, which is the pathway that our immune system takes for the coronavirus, T helper 2 cells, see this guy here, the steroid, it will reduce the formation, it would block the formation of interleukin 4 and 5. How does it do that? Inside the T helper 2 cell, there is a gene called GATA3 gene. Steroid go and suppress the expression of GATA3 gene, which in turn causes reduced production of interleukin 4 and 5, which means B cell activation would go away, which means humoral response will stop. Very interesting. Then on the cytotoxic side, again, here is this dude, the steroid. When the steroid go in the T helper 1 cell, in there is a gene called T-bet gene. They go and reduce the expression of T-bet gene, which causes reduction in IL-2 production. IL-2 is necessary to activate a cytotoxic T cell. So now the cytotoxic T cell is not working and it is not killing other cells that are infected by the virus. So can you imagine that so much of the calming down of the inflammatory system? Then on the T helper 1 cell, the T helper 1 was going to produce interferon gamma, which will then make the macrophages active. And the steroid also reduce the production of interferon gamma. So that means the acquired arm, this arm of the immune system, will not be able to activate the innate arm, that is this arm. So the amplification of each arm is reduced by steroid system. So can I just say in summary that glucocorticoids are going to calm down the whole steroid system? Sorry, I'm saying steroid system. I started reading a comment. The steroid systems are going to calm down the whole immune system. Innate arm is calmed down, acquired arm is calmed down, humoral antibody production is reduced, cytotoxicity is reduced, macrophage activation is reduced, interleukin production is reduced. Essentially, the cytokine storm or macrophage activation syndrome is suppressed. But this is an important statement now. This has to be done in a timely fashion. If the system has run away, then it is very difficult to give steroids and calm it down. I have a patient here, I mention him sometimes, he's in an ICU in Coney Island. And even today I was talking with the doctors, and the same is the problem, that the inflammation was so much run away that the damage to the lungs and kidney is so much that now giving steroids, there is no coronavirus anymore. He's RT-PCR negative. But there is so much damage that has already occurred that we have to figure out how will his lungs start working again, which are severely fibrosed and organized and damaged. How would his kidneys come back? So that is what is the important thing. So anybody who is bothering others, I will block them today. So all I have to do is that after the video, after the discussion, I'll go over the chat and I'll report them to YouTube. So I do not know who is, so Crusher MEC, please tell me who is bothering and I will report them to YouTube. So tomorrow they will be blocked. Okay, so this much clear? So this is the function of the steroids. Now let's see what else do we have. So that's it. So I'm gonna now come back here and look at this protocol once more. So again, in this protocol, I had shown it to you: vitamin C, quercetin, zinc, melatonin, vitamin D, enoxaparin. We just talked about it, that it works with antithrombin and suppresses the active, factor 10. Steroid we just explained. And then after that, they're saying optionally remdesivir, optionally ivermectin, start oxygen if needed, avoid nebulization, avoid ventilator, and transfer to ICU if needed. So this is the discussion for today. Tomorrow we will continue with the Math Plus and we will go to the ICU part and see that what are they suggesting, how to manage the patient in ICU. Got it. So I would block them today, Crusher. All right, so any questions? Is this clear? Was this fun as well? I know I go into details, but my benefit of going into detail is that I believe that you have now looked at the last mechanisms that are possible, and you can now think about it by yourself as well. And then you can decide as a doctor, as a medical student, as a nurse practitioner, nurse, you can decide what to give, when to give, what labs to look at, and how to modulate your response. So that is what my hope is, that this would help. I am grateful for the people who put the protocol together. I'm blessed that we are able to discuss that together. Cool. So thank you very much. And we would continue our discussion tomorrow. Tomorrow we will continue with the Math Plus protocol and hopefully we will finish that. Please, at the end of the day, my request to you, please like, subscribe, and share. Our viewers, I think YouTube has stopped pushing our videos too much. So our viewership is actually going down because they are kind of blocking it, or I don't know what they're doing. But anyways, if you can share it, please share it. If you like what is in here, please share it. and we'll talk again tomorrow. And anybody who's interested in the book project, please tell me. I need help to put that together. There are a couple of people who have said that they can help me. So let's put this whole thing in the form of a book as well. All right. So thank you very much. See you tomorrow.